And when you start to recognize that, you know, by really supporting people and having some protocols and some things that assure me that that is going to get done, and allowing others in the team to do that, we can actually do far more work and actually improve our quality of care dramatically. And as physicians started to recognize that and we started to embrace these teams more, originally we said, you know, it has to be that person. If you substitute that nurse with somebody else, then we have to start from the beginning again. We're not at that point anymore because we've created a role that we clearly know what that role is, and that person can step into that role, and it functions. And the team doesn't disintegrate because of the change of the individual person. What we see now happening is actually others on the team struggling with that shift. And so I watch as the LPNs and the RNs and the nurse practitioner are now in that same struggle about who does what and whose turf they're needing to protect. And so that's an interesting new role identity that's happening. So the other really important piece I think that we've recognized is there is a difference between substitution, role substitution, and role supplementation. So you can substitute a nurse practitioner or substitute in a pharmacist and give them a separate piece, and we tried that. Our first nurse practitioner had an independent role, and it created a new piece of fragmentation and new problems around communication that weren't there before. It didn't solve anything, it just added to that. And as we became much more comfortable with each other and much more interdependent, the whole supplementing of the common goal, the goals of care that we wanted to create, became much clearer. And so we've now moved to a new nurse practitioner role that's a much happier situation for her and a much happier situation for us. In fact, she's seeing my patients today. And when my colleague goes away, she sees their patients. And she really likes that. That's far greater role than having her do patient education and chronic disease surveillance. We now have RNs in that role. So what else did we learn? We learned that quality doesn't just happen because we want it to. We want it to. We want to improve the level of care we provide. But just working harder doesn't really do it. We can, and initially in that first project, that's what we did. We just worked harder to try to get more diabetics and more hypertensives in guidelines. But it's not sustainable, and we recognize that we have to work smarter. We have to reorganize the way we do things. We needed to improve our access because our access was terrible. We needed to improve our efficiency so that we had more capacity and we could be more productive with the time that we had. We have to improve the outcomes that we get, and we had to show leadership around clinical excellence. And every time in that integration committee we started talking about how we could save money, those glazed over eyes came back. As soon as we started talking about how we could provide care better and more cost effectively, that's what drove everybody. And I think that this visible support for our efforts in managing chronic disease better and doing better health promotion and screening has to come from all levels, from the region, from middle management, from us as clinical leaders as well. And it has to be a visible support for clinical excellence as compared to fiscal. So looking then again at our model, with the second phase, with our primary care network, we actually started to talk with the Institute of Healthcare Improvement. One of their projects was originally called Advanced Access, and now is called Office Practice Redesign. And next weekend in Dallas, Texas is their big annual conference, which I'm off to. And it really talks about how we can redesign our systems so that we can be a little bit more effective. The Alberta Primary Care Networks, now there's 26 of them across the province. We have 51% of the family physician population in there. So even though we've got about a half of the family docs, we've got about a third of our population in Alberta rostered within these networks. actually, when you look at it, very similar to the family health teams and family health networks of Ontario. Our particular network, the Chinook network, we created an actual joint venture agreement, which is a formalized legal entity that defines and governs the relationship between the regional health authority and the physicians. Governance is another thing people don't really want to talk about much, but it's a very important piece. 23 clinics, both rural and urban. We have a patient population of 184,000, 110 docs in our region, all of whom have signed on. And we decided our focus for our network would be office and community-based family practice teams. The next entity, this Alberta AIM, which I've talked a little bit about before, is funded to provide collaboratives which will bring in clinics and regional specialty programs like diabetic educators and mental health and home care to actually work away at improving their processes and the way they do that. We've used Mark Murray, who is one of the international leaders in this whole process, and he comes for 2 days, and we have a face-to-face session, and then for 2 months we go back to our clinic and work at those things, and that repeats itself for 5 times for 14 months, and gradually we're training Alberta faculty, and so for the next 2 days, Thursday and Friday, I'm on that Alberta faculty, and we'll be doing that with a group of family docs in rural northern Alberta. The principles are based on this statement: the most effective system from clinical perspective and the most efficient system from a cost revenue perspective, with the most satisfaction for both patients and providers, functions with as little delay as possible. And so the principles are really quite simple. Know your own patients, see your own patients, and don't make them wait. Sounds easy. So is it okay to wait? We say this all the time. Time is a great healer. That's why we keep you waiting so long. So that if we, sooner or later you'll get better, and then we don't need to worry about it after that. We also get into this triage system where we'll see you if you're sick, but you better prove that you're sick first in order for us to see you. So why focus on that? And you know how our patients feel. What do patients say when you go to Safeway? The first thing they say is, gee, it takes so much to get in to see you, doc. I can't ever get in to see you. So certainly patient dissatisfaction is very real. Our staff, ask your receptionist what it's like when you don't have an appointment for the next month. She's being bombarded with people asking to get in to see you. I'm not happy. I know that I'm not able to see my patients in an appropriate period of time. I know that I should be, because they can get sick before I have a chance to see them next time. It certainly costs money because patients come back more often, call me on the phone for prescription renewals because they can't get in to see me. Reduces our ability to see patients, and actually if you have a wait time of greater than 3 weeks, it's been shown that you have 14% rework. In other words, you're working just to support that 3-week waiting time, and that takes capacity and time. Certainly, if somebody doesn't get in expediently, it can clearly affect clinical outcomes. And the most important thing, I think, is that the perception of delay means we need more people. We need another doc. Well, maybe we do, but maybe we don't. Maybe if we make some change, we can actually manage a little bit better. Eliminating delays has become the foundation of improving clinical care. And when we first got into this, we thought, okay, well, this is a process of efficiency in the office. We'll really work hard at getting our access down. And what almost surprised us was that the improved clinical outcomes started to fall out the bottom. As you start to do the right things every time, the reliability and safety improves, and the clinical outcomes actually start to improve. So this is sort of a high-level overview of what it is that we do. And I think the key is that we build a foundation within the clinic. There's a concept that's really becoming popular in the international literature around the medical home. And traditionally in Canada, especially rurally, the medical home has always been seen as the hospital. We've worked hard politically to build this hospital, sustain our community, and by gosh, we're going to use that place.